Good morning, everyone, and welcome to the Public Safety Solutions for Substance Use Disorder ECHO. My name is Julio Sorblanco, and I will be the facilitator for today's session. This ECHO is brought to you by the Center for Substance Use and Training and Telementoring, also known as CSTAT, by Be Well, Texas, in collaboration with the UT Health San Antonio ECHO program. A few housekeeping items before we begin. We have live closed captioning available for today's session. If you would like to view closed captions for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. If you're having trouble accessing captions, please chat Echo IT Taylor. To help us with attendance, please enter your full name, affiliation, and email into the chat. Please remember to stay muted unless you are speaking. We encourage joining by video and using the chat and/or raise your hand feature to post questions or share perspectives throughout the session. If you're having any connection issues, please privately chat UT Echo IT Taylor for assistance. As a note, these sessions are being recorded and will be shared on our website. Therefore, to ensure privacy, no personal health information is allowed at any point during the session. This includes client names, patient names, addresses, birthdates, or any other identifiable information. At the end of the session, the ECHO team will send out a post-session survey link. We kindly ask you to complete it, as it provides feedback on how to refine these sessions to better address your priorities. We're approved for CEs for paramedics and any public safety professional behavioral health degree, such as social work or counseling credential. Finally, ECHO is an all teach, all learn environment, and we do encourage everyone to participate in the conversation and raise questions. With that, we'll move on to some team introductions. First up, we have Brandon Del Pozo.
Hi, everybody. It's always good to be here. My name is Brandon Del Pozo. I'm an assistant professor of medicine and public health at Brown University, also an adjunct professor of drug policy at Georgetown. Prior to this life, I was a police officer for 23 years. 19 were spent in the New York City Police Department, and 4 were spent as the chief of police of Burlington, Vermont. Always love to make it down to a virtual meeting in Texas.
Thank you so much. We also have Cynthia Mendiola.
Good morning, everyone. Looking forward to the session today. My name is Cynthia Mendiola. I am a retired federal probation officer. Worked with substance use disorder individuals coming out of incarceration, and I did that for 27 years. I'm also a trainer and coach in core correctional interventions, and I'm looking forward to being here. Thank you.
Thank you so much. Our didactic presenter for today is Jesse Trevino.
Hi, I'm Jesse Trevino, co-founder and president of SolutionPoint Plus. We're a consulting and training firm that operates in the space where public safety and mental illness intersect. But I did 11 years with the San Antonio Police Department in numerous capacities. But yeah, thank you for all being here.
Thanks so much, Jesse. And our case presenter for today is going to be Mike Sasser.
Hello, how you doing? My name is Mike Sasser. I'm a paramedic captain with Austin Travis County EMS, and I run our substance use programs.
Thanks so much for being here. So with that, let's go ahead and get started with our didactic presentation. Jesse, once you share your slides, feel free to take it away.
All right, hopefully everyone can see and hear me. All right, so thank you for joining the presentation. It's nice to be invited to do this. We'll be talking about de-escalation and crisis response, specifically when dealing with serious mental illness that's untreated, specifically psychosis and substance use-induced psychosis. I do have to include these disclaimers. The first of these is all speakers and members of the planning committee have no relevant financial relationships with commercial interests to disclose, and the views and opinions expressed by participants and speakers attending ECHO sessions are solely their opinions and do not reflect the position or policy of UT Health San Antonio. We'll cover quite a few terms like mental illness, serious mental illness, psychosis, and specifically methamphetamine-induced psychosis. We'll discuss some warning signs of a person being escalated, experiencing psychosis, and then we'll discuss some de-escalation practices to promote safer outcomes. And this is all going to be from a very, very high level, considering I don't have a lot of time. But first, let's start at a very basic consideration, and that is defining terms. So mental illness is simply a health condition involving the brain that's going to influence or affect the person's ability to emote, regulate their energy levels, may affect their ability to perceive reality, and may affect their cognition. And there's a very fancy term that many of you hear often, and that term is disorder. And simply stated, that term means that the person's symptoms, mental health symptoms, are affecting their ability to function in life in some capacity. This might be their relationships, this might be work related, it might be just being in society. And mental illness affects, depending on what year and who's asking and counting, about a quarter of the population. So about 23% of the population will experience mental health uh, uh, diagnosis in this country. But there is a smaller subset of mental illness that we're going to talk about here today. And these mental illnesses were found to substantially interfere with the person's ability to function. So our most mental illnesses might, affect a person's ability to work or get along with people or function in a relationship. These are found to substantially affect those areas to a higher degree. And we know those as serious mental illness. Serious mental illness is actually quite rare. It affects less than 6% of the population. Sometimes we refer to these as AMI and SMI, so any mental illness and serious mental illness. So again, any mental illness affects about 23% of the population, and serious mental illness affects about 5.6% of the population. Now, it's important to get into this discussion because we're going to be discussing serious mental illness as much as we can in the amount of time we have. But I want to make a distinction here. As a person that is diagnosed with mental illness and who operates in an organization that's committed to eradicating stigma, we have to address stigma. Stigma is problematic. It's the number one reason why people won't get help or engage in treatment. So we're going to try to dispel it now as best as possible. The first thing I want to say is people with mental illness are not more dangerous or violent than the general population. We learn over and over again that people with mental illness are actually more likely to be victims and suffer from trauma more than the general population. So that is, people with mental illness are not inherently violent. They're more likely to be victimized. They're not perpetrators of crime. They're victims of crime, generally speaking, compared to the general population. But there's an elephant in the room that's often kind of left out or not addressed. And I think either this is because people don't know or we are afraid to dive into it because we're afraid of promoting stigma. I believe you can have an honest conversation and not promote stigma at the same time. Those things shouldn't be mutually exclusive. So here we are. What we do know and what the research tells us is serious mental illness, when not adequately treated, can be a predictor of violence. Now, not all symptoms of serious mental illness are inherently problematic. We'll get to that. But generally speaking, untreated serious mental illness is problematic for a myriad of reasons. It does predict violence. And then when you introduce confounding variables like substance use, which we'll get to, exposure to violence, trauma, a lack of social consequences, the propensity for violence increases exponentially. And that's something that we need to talk about. And of all the uh, social consequences that exist from untreated serious mental illness, is really going to be the type of crisis that come from this and how we kind of as society are forced to respond. Um, so that's what we're going to be talking about essentially in this conversation. And additionally, I want to add a point. We shouldn't be afraid of people with serious mental illness. That's not what I'm suggesting at all. What we do know is that people with serious mental illness, when they engage in treatment that's effective and adequate, they are very productive members of society. They do quite well and they thrive. So, as a society and from a systemic perspective, that should be the collective focus from crisis responders through the criminal justice system to even primary healthcare responders. That should be the focus in mind because it does society a whole deal of good, not just from an empathetic and humane approach, but from a societal and systemic approach. It's beneficial to promote treatment. So let's get to SMI symptoms and how crises present themselves. There's many symptoms that'll come up through the various serious mental illnesses that we'll know or discuss, but we don't have time for that, so I'll just discuss them briefly. The most problematic that we'll get into is probably psychosis, and I'll break it down momentarily what that means. But something very common, and I will say that this is for me, the hallmark telltale sign of a person with schizophrenia in crisis specifically is disorganization. Disorganized thought patterns, disorganized realities, disorganized speech, disorganized behaviors. So disorganization is a very, very problematic thing. I know a lot of people that work in first responder professions, and they expect people with schizophrenia to just get up, go get a job, take a shower, be productive in life. And that would be equivalent to me handing you all Rubik's Cubes, starting my timer and giving you 30 seconds to solve them. Simple, basic tasks in life can be that problematic for someone with psychosis, specifically schizophrenia, left untreated. Mania is also problematic in the sense that it is this high energy state of being that causes all kinds of behaviors from impulsivity and risk seeking, um, you know, sexual hyperactivity, gambling, spending, the party lifestyle, drugs. It is problematic. I believe that mania is probably one of the most misunderstood symptoms that are out there. And then depression would be the exact opposite of mania. So a lack of interest in things, a lack of interest in pleasure, lamenting death, just low state of energy, no interest in life. And the most problematic symptom, in my opinion, in this context is anosognosia, which is simply a lack of insight. So people can be so sick and they'll never believe they're sick. They'll never believe what they're experiencing isn't real, that they need help. And anyone that tries to help them is kind of seen as that outside force or entity that they're believing. I believe that human beings need insight as far as mental health goes at all levels. And for most quote unquote healthy adults, I find them lacking insight, especially. So at this deep level with such extreme illnesses, it is very, very problematic. You can imagine how difficult it would be to get someone treatment um, experiencing anosognosia. But I want to break down psychosis into a few symptoms. The first of these is something we should be aware of is this thing called affect. So affect is essentially our ability to communicate by displaying emotion. Um, uh, you know, there's many theories in communication that suggest that what's more important than our actual words is how we say things, how we express ourselves. So our enunciations and how we express ourselves through our facial feature expressions. And that's essentially what affect is. Now, if you have an unhealthy brain, that can get affected, that can become distorted. And something I've seen with psychosis that is concerning is something known as inappropriate affect. So it's an inappropriate emotional display that doesn't match what's happening in time and space. So early on in my career, I had just gone to the mental health unit with San Antonio Police Department, and I was sent to Haven for Hope. And there's a woman in the female dorms who was in crisis, and I was sent to assist her. And she is very, very sick, disorganized, speaking in word salads, but she's very, very focused on something outside the window, intently focused. So I used an open-ended question and I asked her, what does she see? And she proceeds to tell me that there's spears in the ground, and impaled on these spears are infants, babies, and there's crows eating the baby's guts. And as bizarre as that statement was, as soon as she says this to me, she begins to laugh hysterically. I'm talking belly laughing, holding her stomach, tears, holding her mouth. She's laughing so hard. And of course, the hairs in the back of my neck stood up. And whenever people don't understand, they become afraid. I didn't know what the symptom was. I just knew it was bizarre. I would later on learn to find out that this was an example of inappropriate affect. And if you've never seen it in real life, I would encourage you to watch the movie Joker. There's a good visual representation of what inappropriate affect is in that film. There's also flatter or um, blunted affect, which there's no emotion. People refer to this as the thousand-yard stare, or people will just look through you. They display no emotion. They may almost seem catatonic, if you will. Both of these are symptoms people may experience. Now, hallucinations and delusions. These two things are sometimes convoluted and they should not be. They're very different. Now, they're both distortions in a person's reality, meaning they're not really happening or it's not a true thing. But what I will say to you, and I hope this sticks with you, the first step of the escalation is I promise you that person's experience is very real to them. It's very real to them. So it may not be true, but it is a very real experience for them. These are real distortions in reality. So we should never use logic. We should never try to convince them that what they're experiencing is real or not. It's all right to address it up front, i.e., I believe that you do see that happening right now. I don't, but I believe that's very real for you, and I imagine that's scary. And then move on. Never use logic or debate a person's symptom with them as far as it being real or not. It's not going to land well for you in a crisis situation. Delusions are distortions in reality that involve a fixed belief about the world around you or how you operate in it, despite overwhelming evidence to the contrary. And a hallucination is simply a distortion in reality that can affect your five senses. So we'll break them down right now. Visual hallucinations are things that people see that aren't real, but for them it is. Again, it's a sensory distortion. Not all visual hallucinations are going to be as dramatic or as scary as the woman that I just talked to you about at Haven for Hope in that crisis years ago. The most common visual hallucinations are actually shadows and flashes of lights, halos, things as such. Even when people are at baseline or engaging in treatment, they may have symptoms, but those aren't problematic. When they get problematic is when they start affecting the person deeply. So people might see demonic faces in their families, or police officers show up and they're seeing demonic faces. One gentleman I remember he believed that he was seeing meat and blood seeping out of his walls to the point where he was hosing down with soap and water as if one would wash their vehicle. He was washing his living room. So it can be that real and problematic for individuals. Um, we should ask about things that we notice, just like I did with a woman at Haven for Hope, right? In most cases, they're very aware if they've been sick a long time that what they experience, other people don't. So it's very appropriate to ask, what do you see right now? Um, or if you want to use a close question, it can be appropriate. If they've been sick a while, they're aware that, they experience things others don't. So tell me about something you experience that no one else does. And usually, because of their illness, it's never explained through logic. They'll say, well, I have a special power, I'm given this ability, or I'm sent by God, so I have these abilities. Again, logic will never work for you, but that's how they self-explain in their mind. The next one I want to talk about is auditory hallucinations, which is simply people will hear sounds. Um, they'll hear whispers, they'll hear noises. Right now, if a bird flew right into your window, wherever you are, many of you would turn to look at to see what happened. It's instinctual for us. Our brain wants to know where that sound came from. Eyes track the sound. So if you're dealing with somebody and you don't know what's going on, and you're seeing them kind of flinch or look around, look at the ceiling or look beyond you, it's all right to ask about that. Don't be afraid of offending someone. If you're always coming from a place of sincerity and empathy, it's always going to land well. Again, if they've been sick a long time, they're likely very aware that what they experience, other people don't. If you just ask, you're going to get answers. There's one particular type of hallucination that's auditory in nature that we should be concerned with, and that is a command auditory hallucination. So people can hear voices, most often they're benign, but in some cases, people will have voices telling them or commanding them to do very specific things. In some cases, it's as simple as close the refrigerator door, not problematic. You need to go burn down the elementary school. Very problematic. So what voices are saying matters. So anytime someone tells you that they're hearing voices, you should usually ask, what are the voices saying? And there's no right or wrong answer to this, I believe, but as long as you're chasing the rabbit as far as you can down the hole, ask more questions, find out more. Don't overwhelm them. Be interested and empathetic in asking. And if it's something that involves self-harm or shooting up a school or jumping in front of a bus or murdering my neighbor because they're a demon, you should then ask, is that something they want to do? Is that something they're going to engage in? Those questions matter for a decision maker. But please ask about command auditory hallucinations. Tactile, people will feel things on their skin. Bugs crawling of the nature, so they'll pick at their skin. One woman, it was so severe and so consistent that she went through extremes to kill the bugs on her skin using chemicals, and she ended up with chemical burns on her skin. People will smell things that aren't there. One gentleman in particular, I remember, was smelling what he believed to be human feces and semen cooking because the downstairs neighbors were witches and they were casting spells by putting this together and cooking human feces and semen. And he went through such meticulous behaviors to try to stop the smell, filling the grout floors with liquid soap or laundry detergent, flooding the baseboards, duct taping every seal he could, flooding his vents with dryer sheets. That's how real the smell was for him. Simply, it isn't something they imagine. It's not in their head. It is a distortion of their sense. It's a sensory distortion. So it's very real for them. And his level of anger had gotten so bad and frustration that he had a plan to kill these witches, his downstairs neighbors. And then gustatory hallucinations, people will taste things that, poison or stuff in their food. My largest client is the Federal Bureau of Prisons. We teach de-escalation at Federal Bureau of Prisons, and what's common that I find in that setting is people will taste, they say, corpses in their food. It's a very common gustatory hallucination there. Now, delusions, these are beliefs. I've never found a jealous delusion in a crisis before. I'm not saying it's impossible. I've just never seen it. I don't mention it often, but it's probably going to be something you'll find in workplace drama issues or in a relationship. But it's this belief that someone's going to betray you without any evidence supporting so. Um, what I have seen is grandiosity. People will believe they're the smartest person in the world. They're a god. They're, the second coming of Christ. They will believe that they have special abilities. One gentleman believed he was the sexiest man in the world, to the point in the workplace he believed that any man that would ask him for anything or worked with him had a plan to rape him. And this became super problematic to the point it escalated to HR, where they ended up terminating him because he wouldn't stop, you know, causing all these issues. And he got so angry that he wanted to commit workplace violence with the mass shooting there. But he really, really believed this. And I'm not sure that I would be one to discuss a person's looks in one way or another, but let's just say that this gentleman was not, I don't know, Brad Pitt or whoever the sexiest man alive today would be. But he really believed he was. The two dangerous ones I'll say, and I say danger with the risk of violence, are persecutory delusions and erotomania. So persecutory delusions involve a belief that people are after you, they're coming to get you, they're going to harm you. It's usually a nefarious group or a government group. One gentleman believed that the KGB was coming after him. So he was hiding in a Sears, trying to keep his head down. And some poor gentleman was probably just looking at a laundry system for his wife, a dryer, washer, and maybe got too close to this guy, and he assaulted him violently. With the same gentleman in a different series of events, so consistent delusions with him, he was dropped off at an emergency department, which we know we shouldn't do in Texas, and he leaves, jumps into a car that's on in front of the emergency department, steals it, drives at a high rate of speed, rolls his car on a surface street, miraculously doesn't hurt anyone or himself. But he did all of this because he was trying to get away from the KGB. So with persecutory delusions, we should be very concerned with how will they defend themselves, right? Ask questions like, what would you do to protect yourself from this threat? That sounds very serious and scary. Validate their fear. I can't imagine what that must be like. That sounds terrifying. How are you going to protect yourself? And you'll be amazed that the answers are given. I'm going to make weapons. I'm going to get a weapon. I'm going to set a booby trap. It's a real concern. Erotomania is this delusional belief that you are in a romantic relationship with someone you never could. Usually this involves a celebrity figure or someone in government. And this leads to, of course, stalking. But honestly, the most significant area where violence occurs is usually in the barrier to individuals. So the handlers, the security staff, the people that are really in relations with them, they can be threatened. And then, of course, if they ever do meet that person that they have this belief about, they're not going to get the emotional response they want. So it activates a negative emotion, usually anger. So that is something to be concerned with. And then somatic delusions, I believe, are super problematic to a person's self. They can lead to self-harm. So people believe that there's something implanted in them. There's a limb that doesn't belong to them. There's an alien growing inside them. There's a tooth that's tracking me, a chip in my brain. If you're familiar with the movie A Beautiful Mind and book, Dr. Nash believed he had a device inside of him. And when he is committed, he chews a hole in his forearm. And as soon as he sees that the device isn't there, it's not like logic kicked in and said, oh, I must not be well because the device isn't here. No, his brain would not allow him to rationalize it. It just adds to the delusion. Someone took it out. They took it out. It's gone now. So again, logic won't serve you, but people will go through extremes with somatic delusions to remove the foreign entity, which is a self-harm. And then you can have combinations of all the above. Now, I want to get into drugs as quick as I can. The two drugs that we need to be concerned with psychosis are THC and methamphetamine, and for very different reasons. Um, I know there was a large push for marijuana use for various reasons, and I'm not going to get into that debate. I do want to talk about the reality of, in this context, though, there has been an uptick in many measurable ways of psychosis experiences with very, very young teens because of THC. From the amount of people being hospitalized in emergency departments for psychosis going up and even higher for young teens, to now we know for sure that THC is responsible for activating the schizophrenia genetic marker at an earlier age. We used to see schizophrenia, people having their first psychotic breaks in their late teens, early 20s. And over the past 20 years or so, that age group has gone younger and younger. And we now know through experimental design that this is because of THC. So that is a extreme concern there. So, all I say is you have young people in your life and serious mental illness ones in your family or not, there's something that you should discuss because marijuana isn't as safe as many people assume it to be. I want to spend a bigger deal of time talking about methamphetamine psychosis. Um, Methamphetamine psychosis is its own beast, if you will, because it is different than what I've seen with, let's say, organic mental illness. Early on, methamphetamine psychosis shows up in a very, very specific way. It will result in paranoia stemming from a persecutor delusion, usually from a nefarious group. And that's usually the only symptom. You're not going to find disorganization. You're not going to find any other state of altered reality for them early on. It's going to be this hyper focus on, I don't know, the Mexican mafia coming after me, and they're not safe. And if you don't support them or see it their way, they get very, very angry. They are very, very concerned with using violent means to protect themselves from this perceived threat. But the bigger problem with methamphetamine usage is as it progresses into later stages and causes sleep deprivation, the longer a person stays awake, the worse the brain gets, and then more symptoms come, exacerbating everything. So what I tell people is if you are dealing with you believe to be methamphetamine-induced psychosis, you need to reassure safety often, reassure safety consistently. Remind them that they're safe and you'll do everything they can to keep them safe. And to the point where it sounds redundant and may even sound silly, but it's very, very important, which is going to lead me into some de-escalation tips. The first thing I'll say is because I know there's a myriad of people from a spectrum of groups in here. Follow your laws, follow your policy, and trust your instincts. Not everything that you're going to come across merits a de-escalation or is in your purview to handle. So always consider your safety first. We want to, as best as possible, speak low and slow, clear and brief language. Um, in the corrections world, I know this isn't popular, but it is proven in science. Use the person's first name. Use their first name often. I know that's a big issue in corrections. You guys don't like it. I'm just telling you what social science tells us and what I know from experience. Using the first name helps. Use the active listening skills. And again, it's active listening, not active speaking skills. You need to be listening to them. Follow the 80-20 rule. You should be listening 80% of the time and speaking 20% of the time. Don't try to problem solve these individuals. Don't try to solve their problems. It's not going to work well for you. Problem solving should not come until after they've been de-escalated. That can come later. The way we do this is by using the active listening skills and remember person over problem and connection over correction. So focus on the individual, not their negative behaviors, not what they've done. Focus on them and try to establish a connection before you correct any behavior. Again, if they are experiencing psychosis, there is a high likelihood that they may be paranoid. And if this is meth-induced psychosis, I say straight to this. You can't do it enough. Reassure safety often. Let them know they're safe, that you're there for their safety. You want to keep them safe. And then you can follow what we call the CCRTC model. This is SolutionPoint Plus. Our methodology, you can find Joe's book Unarmed online or take our training. But we believe that curiosity will lead to connection. Connection will bring you rapport. Rapport brings you trust, and then trust will get you to compliance. It should be a dissension. I know the FBI uses the active listening staircase model or the behavioral change staircase model. That's an ascension. We believe in descension. Um, you cannot get behavior change without trust. And I know compliance is a touchy word for people. We're just discussing the idea of getting a difference in behavior change. You're getting the outcome you want. And you can't get that without trust. And to get trust, you need those first three things. I know you do tremendous work, and I appreciate all the work you do. All of you are valuable, and the work you do is immense. So we appreciate it. I will say that um, a lot of us are idealists, and we can't save the world as much as we want to and try. So I'll just leave you with this quote from my uh, co-founder, my best friend, and my CEO. We don't have all the answers. What people need most in crisis is to feel heard, valued, and safe. Show up with empathy. That's where real impact begins. But thank you for your time, and thank you for allowing me to do this. I'll stop sharing now.
Great. Thank you so much for that presentation, Jesse. It was very, very informative. Um, Top props to you from my side. But at this point, I want to open up the floor to the Learning Network. I see Kristen has her hand up for any questions, comments, thoughts, or anything you want to pose for Jesse. Go ahead, Kristen.
I wanted to know, first of all, thank you very much for a very thorough presentation. I I I know this is a big problem in Texas. Stimulants have reigned supreme forever, and then we added a bunch of fentanyl. Um, I wanted to get your thoughts on. So Texas has the highest number of uninsured individuals in the country. We're a non-expansion Medicaid state, and we rank dead last in access to mental health care. So, like you were mentioning, there are people that you will see over and over, and I hate to use the term treat and street, but sometimes that's what happens. Can you share some comments on how that um, contributes to compassion fatigue, moral injury for the first responders, and then how does that affect outcomes?
Gosh, that's a great question, Kristen. I wish I should be an entire session in and of itself, right? The first I'll say is I just mentioned that serious mental illness left untreated is problematic uh, for a myriad of reasons. It causes a lot of social issues, and the focus should be treatment. And we do know that a large majority of people with serious mental illness will not get any treatment for that matter, and at best, the treatment they get is inadequate. So it's going to cause a lot of issues in the state. People often ask, how did you and Joe get so good at this? We didn't come from the land of rainbows and unicorns. We came from a state that was pretty jacked up. And when you leave it to the front line to figure these complex problems out, you learn a lot. So I also did see a lot of first responders get very, very frustrated. And I got to the point where I was kind of amazed. And if there's any nurses or ER doctors in the room, please take this with love. But in a lot of places, I would teach his officers to be super compassionate and empathetic and bring somebody, right? They bring somebody in crisis. They got them the trust. They got them the vehicle. They got them there with this bow tied here, help them. And as soon as a nurse or doctor saw them, it would be like, who the F is this person? Why'd you bring me this? Or a junkie, arrest them. And it would kind of reignite the whole escalation and undo all the work officer just did. But in all fairness, that is because of what you just mentioned, this compassion fatigue, this frustration. It's this revolving door that, there's really no answer to. But I do believe that there are still solutions, even with the limitations we have. And as this group in and of itself is a product of that, you wouldn't have seen this group, a decade ago. But just having people from different aspects of the system work together and speak collaboratively is a huge thing. But I do believe there needs to be unified effort between local mental health authorities, hospital systems, and criminal justice systems to include court groups and corrections, not just cops. That collaborative, there's a lot of that can be done. And I wish there was a better answer for you. I do, but that's a really good question. I answered the best I could.
Thank you. You can always come back and do a presentation on that as well.
Yeah,
Yes.
Stephanie, I see that you raised
Morris.
a question in the chat. Would you be able to unmute yourself to ask your question?
Sure. I was wondering if you could talk a little bit about after a person has entered into recovery and they're still dealing with feeling like their delusions are real from when they were using like lingering delusions. What's the best way to support someone like that after they've entered into recovery?
so I I I don't I will say this, right? I'm going to speak of this as you mentioned from a supporting aspect, from a caring family member. I will say that my expertise is in the crisis and de-escalation lane. This is we'll get into the realm of maybe a therapy-based question. I would first say that's something that should be communicated to the primary care provider, whether that be a psychologist or therapist, right? That information needs to be there. But if you lead with empathy, it's always going to help you. So just acknowledge that they believe this thing and let them know that it is, not an experience and this is happening because they're sick and you're concerned about them. If that leads to an escalation and you're good with these skills, that's okay. Joe, this is a delicate practice, and I call this an advanced skill set. Joe sometimes will refer to this as poking them in the eye, and this is useful if you have a rapport with somebody you've been working around a long time or they're a direct family member. And you'll tell them, look, as long as you don't listen to the doctors, as long as you don't listen to me, as long as you don't get the help you need, this is going to keep happening. This is scary for you, and I'm sorry it's happening to you. It's unfair that you have this illness, and it's unfair that you have this experience. But as long as you don't do the things you need to do, we're going to keep going through this. And I don't want that for you. Let me help you. Um, I would not do that unless you have a very good relationship with the person and you're very good in de-escalation skills. Because when you call somebody out and tell them flat out that what their experience isn't real, it's a really, really good escalation. It's almost guaranteed. I'm okay with doing that because I'm very comfortable with de-escalating. So it is an advanced skill set, and that's what I recommend. But this may be a more therapeutic question for their primary care provider to help them with. I hope I answered that enough.
Yes, thank you.
Great question.
Definitely great questions. In the interest of time, I do want to go ahead and move on to the announcements. With that being said, though, definitely love the conversation. Keep posting your questions in the chat for Jesse. Jesse, if you don't mind answering those questions, we would
Oh, yeah.
definitely appreciate that. Taylor, whenever you're ready, if you could please bring up the announcements, please. Thank you so much. So to claim your CEU credit, you must complete the post-session survey in the chat or by email sent after the session. Complete the post-session survey and select yes on the question, are you applying for CEU credit for today's ECHO session? Your certificate of completion will be sent to you 2 to 3 weeks after the session date. If you do have any questions, feel free to email bewelltexas@utesca.edu. Next slide, please. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics through our network of subject matter experts. To request technical assistance, please complete an online request form through the link in the chat, and we'll be pleased to help you. Next slide, please. The Texas Substance Use Symposium, TexasUS, is back March 2nd through 3rd, 2026 in San Antonio, Texas, and we're thrilled to reunite our statewide community once again. We're also excited to introduce a new TXSUS Regional Summit this fall in El Paso. If you're in the area, stay tuned, more details coming soon. For the latest updates, visit txsus.org. Next slide, please. Join us for our next TXSUS session with speaker John Kamola on a discussion on how to evaluate and navigate through today's policy and funding landscape. Register today by scanning the QR code or by visiting the link in the chat. Next slide, please. And lastly, please join us next month for another Public Safety Solutions Echo on Thursday, July 10th at 11 a.m. Thank you, Taylor. Let's go ahead and move on to our case presentation for today. Taylor, if you can bring up the case form. Mike, please walk us through the form.
Hello. This particular call, the way this happened was it was a dispatch to one of our rural areas. For those of you who aren't familiar with Austin Travis County EMS, we handle the city in downtown Austin, but we also have some little more spread out areas out in the county. And this was one of the ones that happened in Del Valley. It was about 7:30 in the morning. Field crew was called for a heroin overdose. Actually, the call was actually dispatched as a cardiac arrest. The client or patient had been using black tar heroin that day and experienced an overdose. He was given 4 milligrams of Narcan by a friend at the scene, and then given another 4 milligrams by the fire department prior to our arrival. So when he started, he woke up and kind of became pretty having precipitated withdrawals from the Narcan and was extremely sick. He really did not want to go to the hospital. And things started as he was a little bit agitated because he was experiencing withdrawals. He got escalated. Sheriff's deputies kind of got escalated as well, and they were threatening to take him to jail. And they really were insisting that they wanted him to go to jail because it would force him into a treatment, some kind of treatment, and getting some help for his substance use. So while their motivations were correct in trying to get him help, their method wasn't the best one. And our field crew called out for one of our community health paramedics, who is part of what our team does. I believe in San Antonio Fire, they're called the MIHOs, the Mobile Integrated Health Officers. For their program, we're a specialty unit that focus on mental health and substance use, and basically everything that doesn't fit in an ER kind of thing is what we try and address. Um, our team showed up, realized that he was in precipitated withdrawal because he had a COW score of 19. So he was experiencing significant withdrawal. They dosed him with 16 milligrams of buprenorphine. And just seeing him over the course of the next 30 minutes kind of stabilize, his repeat COWs was 4 after it was all over with of the monitoring. Um, and he was very excited and became very positive and was willing to engage with anything that we offered. What he asked was, "Can you help me stay on this medication? Can you help me get help from here?" And so our crew from the scene of the overdose actually scheduled him an appointment at an MAT clinic about 5 days later. I think the 17th was actually, and this call happened on the 11th. And so 5 days later, 6 days later, he went to the clinic. He also became so excited, he asked if we could help his girlfriend as well. So after we kind of de-escalated the tension, and they decided that he was okay to stay in the community, we actually connected with his girlfriend and made a safety plan to get her some comfort meds to have her wait for a day or so. And then the next day, when she had been farther removed from her last use, we went ahead and started her on buprenorphine as well, scheduled an appointment at the clinic, and carried them for about 5 days until they connected into treatment. And the last time I checked, they'd been in treatment for 4.5 months.
Great. Thank you so much for that, Mike. Um, at this time, I would like to open up the floor for a case discussion. Are there any questions or comments from our team or learning network for Mike today?
Hey, this is Brandon. Mike, that's a really interesting case. Could you say a little more about the field induction, like induction into buprenorphine in the field? Because I think it's really innovative and has the potential to be a big positive change. And I know very few jurisdictions are doing it. So I think that's one of the things that's really worth exploring a little today.
Yeah, we've been doing this for 5 years now. This November will hit our 5 years of carrying buprenorphine and doing it. We've spread it out. Like originally, when we first started, it was kind of a very wonky thing because nobody had ever done this in EMS before that we were aware of. I think actually it was Camden, New Jersey, San Antonio, and then us that kind of got access to it and started doing it. And initially, they were very hesitant how they rolled it out. They basically put it in my hands and said, "Okay, go do this," and just left it at one person. And then as we saw just how much need there was to connect people and get people started and get people started in a safe way, just getting them started and stabilized so that they can go to the clinic and actually engage with the clinic was huge. And so like everybody thought we were going to run out of meds in the first 4 weeks or first like we were going to expire, actually, that the meds were going to expire and that we weren't even going to use them. But I burned through 4 months worth of meds in the first 6 weeks of the program, and we had to reorder, and we actually ended up doing like 112 cases in the first year of bridging people across that. And so we've been doing it now, and like I think our success rate of people who start on medication with us and ultimately connect to another program is around 93%. We tend to stay about 91 to 93. So if we dose you with meds, you're going to connect to something else is kind of our.
And what percent of people is sent to be dosed with meds, like consent to be dosed with goop
So
in the
we
field?
we we've kind of looked at that because it's not really a hey, if this situation presents itself, then you offer meds. It's a matter of like tell us when you're ready. And so we're really kind of taking the low-hanging fruit and just telling people like when you're ready to do this, we can help you get started to get moving towards it if they're not ready in that moment. If we get the call from a field crew and somebody's like actively experiencing withdrawal symptoms and wants to engage, we'll come out and start you right then and there. All you have to do is be ready for it or be willing to engage is kind of what we do. And so anytime it comes up of people wanting to do it, it's not just with overdose. This overdose piece of it is huge, and I see a very big benefit to do it as this one went really, really well. And so far, we've not had any of them go poorly. There's very low risk to starting somebody on medication after an overdose because you're not going to cause precipitated withdrawal from it. So it works really, really well.
So I wanted to touch on that a little bit because you said you're not going to cause precipitated withdrawal, but there is research. I'm glad to hear it, and I don't pretend to know what's going on in the field, as a matter of practice, but a lot of people who use drugs say buprenorphine is the thing that sends me into precipitated withdrawal. Like, and I've done qualitative research where people who use drugs will sit across the table from me saying, I'm not taking bube, it sends me into withdrawal. Do you see any of that? I understand why you say it wouldn't, and it in fact does relieve withdrawal, right? That's meant to stave off
Right.
withdrawal. But there's something about, especially with fentanyl, they said I was fine taking bube when I had heroin in me, but fentanyl and plus bube equals terrible withdrawal. And there is
Hmm.
something about the way fentanyl is present in fatty deposits that does seem to like um, support this a little. I mean, I'm not like trying to pontificate or I'm not trying to contradict. I'm just saying like this is the kind of messy thing we're hearing. Are you hearing any of that, or am
Yeah.
I
Oh,
making
yeah.
something up?
100%. What I have found through the the many times that I've done it out in the field is that if we go conservatively, because I only feel like I feel like when I hear a lot about precipitated withdrawal, it's usually when they do it on their own. With our people, when we start them, we're very conservative in how we approach. We start with an 8 milligram dose and really watch them for an hour before we give a second dose. Except for in the event of a precipitated withdrawal from that, we'll start with 16 if the cause is in moderate range or higher. And so what I have found is like giving them comfort meds and really trying to help coach them up to a place where they're ready to do it. And sometimes it does take us 4 days since their last use to get them buprenorphine. So being really conservative has been very, very helpful for us, and it has worked. But we haven't really had any issues with. We've had some instances of precipitated withdrawal, but every time we've had that, it's usually been a matter of they're not being completely open and honest about their last use and how long it's been, and they're just trying
Right.
to gain.
Interesting.
And so
Yeah.
going very slowly and conservatively and trying to help them, coach them to a place where it's ready to start. And our team's really nimble. It doesn't have to happen at the scene of a 911 call. We can also say, okay, let's make a safety plan, and I'll come see you tomorrow when you get to that place.
Oh, great. And if anyone has a comment, by all means raise their hand, but I'll continue if until folks raise their hand. Um, and so you notice, I mean, in the case, the patient was a little bit combative or gave pushback. Meanwhile, you had officers that wanted to arrest the person in order to, get him to jail and get him clean. So, number one, it's rare, like in research, that we find that in looking at least EMS and police records, that people are combative. So that seems to be like an exception, but withdrawal can definitely um, spur that on or bring that out in someone. How much of it too may be the case in your experience, this case or others, where the person is resistant when officers are on the scene because they know if I end up in jail or I end up like going to a place where I'm not getting buprenorphine, like I'm going to go into withdrawal and it's going to be the worst experience of my life. Or if I'm precipitated withdrawal now, it's just going to get worse. So you have cops saying that person's giving me attitude, that person's resisting us, they need to go dry out. And then the person saying, hell, if they send me to dry out, I'm going to go into the worst withdrawal of my life. I got to fight this. Like, what's that? Does that dynamic happen a lot with? And what do you do as a medical provider to try to school the cops on this?
Yeah, so what I found a lot of, I mean, giving him medication and reducing like the temperature in the room was a huge part of it. I know that Adam, the particular medic who did this, has a lot of experience and when de-escalated a little bit as best he could with it. But I agree completely because it's like that's the part of with the withdrawal is like withdrawals can be psychosomatic to an extent. From one of the conversations I had with one of the doctors at our local methadone clinic, she said that she'll have people be completely fine until they get there and realize the door's locked and they missed the dosing window and they're not going to get dosed till the next day, and then they have full-on physical symptoms from it. And so what I have found is I know that like the psychosis or the mental piece of it of looking at the situation can get they know how bad it's going to be and they get worse. I've actually talked about that a lot with our team about how they know it's going to get worse and you try and do your best to kind of talk them down and de-escalate as best you can to help reassure that we can work with you, we can help you get some treatment and that kind of stuff. And so I think that's part of it. That's definitely I think that's a huge part of it is the idea of like I know how bad this is going to be, so I'm going to fight this at any chance I can. And I think in that particular situation, it was like he was just like I think people have in the drug using community have an attitude towards law enforcement in general because most of them have had a lot of negative experiences with law enforcement. Um, but it's frustrating because like we have some really great law enforcement officers in Austin who like reach out to me saying, "Hey, we've had to Narcan this guy like multiple times. Can you help him, please?" And I'm happy to. We love being able to do that to work together with them to do that. But I think sometimes just having us there to kind of remove that and say this is not a law enforcement issue, let me help you, and that will help to de-escalate it a little bit. But yeah, I think the fear of what's coming, how bad it's going to get, is a huge part of it.
Yeah, yeah, no. So there's a little bit of the actual medical withdrawal that's making people combative, and a little bit of the fear, maybe of if I end up in the lockup, it's just going to be hell for
Yep.
quite some time. Yeah.
Yep.
Were cops
I think
responsive
it's
to being told? Yeah, go ahead, please,
I'm
please.
sorry.
Someone else.
I think I love this discussion. I think we saw in our presentation that trust is the biggest thing, And so when an individual knows from experience the fear of that withdrawal, and then also the interactions of, what they've had in their past experience, whether it's with law enforcement or other entities, it's important for the people that they're working with at the present time to build that rapport and that trust because that's really important. The trusting of, everything's going to be okay. We're going to be there and we're going to help you, and that they they experience that success in their moment.
That's very true. And I think another factor may be based on what you mentioned about those officers, like their line of thinking. And I'm sure they've been told they're aware of all these like different, drug courts or, treatment program diversion programs. And and I imagine that in their mind, they're like, oh, this exists, so it'll get them help without thinking about the person first, right? So going back to, and I'm glad that, Cynthia said this, um, making it person focused, right? What is their experience? Like, why are they behaving this way? One major premise for curiosity is considering the question, what else could be true? Like, what is it about this that's being escalated? And I think Brandon hit it on, right? That person's experience is why they're right, what they're anxious about, what's about to come for them that they're very aware of. So those are very, very important, but you can't get that or think about that until you are person focused and thinking. But it sounds like there's great programs up there that these officers are aware of, and the simple answer was like, "Oh, if we arrest him, he'll get that help." But it isn't quite that simple. But I do appreciate the fact that you're an agency that's going beyond, hey, pump a full of Narcan and kick him in the butt and get him out of here. Like there's actual process here to treatment, which is pretty impressive. So thanks for that cool case, Mike.
Happy to share. If you got any questions specifically about our program for anybody, by all means, feel free to reach out to me. We're happy to share everything we've done. We're coming up on 5 years, so we've got quite a bit of experience with it, and we've done well. The program's gone well.
I think there's a lot of important things also that came up in the presentation with you and with the presentation, and that's a lot of like you hear experiences where you see other personnels like medical personnel burned out. They're burned out with seeing this over and over and not seeing any success. And I think that it's important that we train our individuals working with people with substance use disorders, to understand that you can't. It's not a quick fix. It's not a cure, and that it's a process that we have to go through with individuals with patients, trust, establishing rapport so that they can have better experiences as they recover.
I agree completely. I think one of the things that I kind of preach to our team all the time is like I was a paramedic. I've been a paramedic for over 30 years, and I spent a lot of time in the back of an ambulance. And every time you ran an overdose call, there was nothing you could do for that person except maybe try not to be a jerk about it. And I wanted to create a program that would give us the opportunity to do more than just do that. And so I consider us and our team as a tool in the toolbox of the field crews, so that when they're in that situation, with sitting there with somebody who's filled with regret and shame and hating themselves and all the things from experiencing the overdose, they could say, you know what, we'll do something for you. Here's Mike's phone number. So that's how this whole thing got started.
And I have a question too, if I may, Julio.
Yep, go for it.
Yes, you mentioned in the case it looks like this person's partner is still using. How was the experience for you as a responder in that scenario? Was the partner there? Was the partner receptive, helpful, or not to your interventions and to your suggestions?
You're talking about the patient's partner from this case study?
Yes.
Yes. So she was not there at the scene when that happened. It was he wanted to call her because she had been wanting recovery, and the two of them had been trying to figure it out themselves. He had tried medication before and sent himself into precipitated withdrawal. Once we kind of talked to her, we were able to get her some clonidine and some Robaxin and some Zofran comfort meds to kind of bridge her into it a little bit and kind of get her farther away from her last use of fentanyl. And once she got a taste of how it could feel better and how she wasn't getting sick, it went really, really well. She was really, really motivated.
Great. I think these are some really, really great points of discussion. And I do want to acknowledge Kristen's comment in the chat. Definitely very, very on point with our conversation for today. In the interest of time, I do want to go ahead and move on to our case summary for today. Brandon, would you please provide us with a brief case summary for today?
Yeah,
Or
thanks. I'll
sorry,
touch on that
recommendations.
case summary, but the didactic session, I think the didactic session was important because a lot of times when we confront people that need to be de-escalated or we need to be mindful of their crisis, it's often an emotionally based crisis. Somebody who's distraught over something like a relationship or job loss or stress in life, and police officers and EMTs are trained to communicate in a certain way to de-escalate. However, with methamphetamines, you get a whole range of at-risk behaviors that mirror an emotional crisis, right? But are driven by very discrete physiological and pharmacological factors. And it might not only be just communication and time that like fixes or ameliorates it, de-escalates it, right? But you also need to know that there's like literally a chemical process that's going on in the person, and be aware of that and be aware of that, the special requirements for that and the limits of some other approaches. So I thought that was a really, really useful didactic session. As far as this case, you could tell from the beginning, police and police officer who dealt with a lot of folks that were entering withdrawal unrelated to overdose. I responded to somebody who we realized we had to arrest for a crime, who this was back like years ago for me, who was addicted to he had opioid use disorder. And that person resisted arrest harder than anyone else I've ever met. And it didn't occur to me at the time, just not knowing what I knew about addiction, that they were deathly afraid of going into withdrawal while being incarcerated. And that was really what was motivating the fight. So the idea that whether you're responding to an overdose or whether you're responding to another situation where it's police and medical providers and a person with OUD in the mix, the idea that you can dose somebody buprenorphine right there in the field, and if it's done well, and if it's done based on a well-developed protocol, that can not only stave off the withdrawal, but make them more amenable to voluntary compliance with whatever else you're going to do, is really a pioneering method. And the idea that you've done that for 5 years already, in New Jersey, for example, has been doing it for several years, but there are other states, vast portions of the country, where this is not even on the table as a medicine evidence-based response to withdrawal and resistance, so to speak. I think is a shame. So it's great that you're doing it. I hope the practice spreads, and I hope people paid attention to the case. Thank you.
Thank you so much for that case summary and summary recommendations. And thank you all for joining today's Echo session. As a reminder, to earn continuing education credits, please complete a post-session survey using the link in the chat. If you would like to present a case, please email BeWellTexas team at bewelltexas@utesca.edu. And we look forward to seeing you at our next session on Thursday, July 10th at 11 a.m. Central. Have a great rest of your day, and thank you for making all of these sessions great.